Dr. Jared O. Mecha is in the studio with us today. Good morning, Daktari.
Morning, and thank you for having me.
Karibu sana. Welcome to the Situation Room. It's Kenya's biggest conversation, and you are in the hot seat today. We're talking about a hot topic. It's World AIDS Day. There are many things that have been said about HIV. Over the last 10 years, we've seen quite a lot in change, and maybe new things. And you're here to tell us all about that today, even as we mark or commemorate this day. But I'm looking at your titles, Daktari, and there are many acronyms. MB, CHB, MMed, MSc, MPH, FCR. Whatever do those all mean?
Oh, that's the baking I've had to go through to be here.
Come out as a full cake.
Yeah, it's it's the oven.
It's the oven.
Yes.
You have more acronyms than an NGO. You're well baked.
Thank you.
Of this baking, you obviously have been involved in HIV research, HIV strategy, learning. And here we are celebrating many, many years since HIV was first discovered in the world and then discovered on this side of the pond.
Correct.
Where are we? I mean, even as we go into commemorating this World AIDS Day, where are we today? Before we even start going into, the details, give us the scope of your work over time.
Yeah, so thank you for having me, and it's nice to meet an old friend that we also worked with a while back at the University of Nairobi. So I think where we are, I can confidently say that we are at a tipping point where you can either tip right or left, and we are all hoping that we can tip right. I have been in this space for about 20 years, but actively about 15 years, really managing reasonably large projects that are bringing help to people living with HIV or those at risk of HIV. So that's the space I have been for about 15 years, yes.
Yeah. How has HIV and the study of it developed? How has it morphed? When first we saw hordes of people dying, families left, without their breadwinners, young children being taken care of by grandparents, entire villages, towns being wiped out. And then where we are today, where we are saying those young people who were taken care of by their grandparents are the ones now who are leading in terms of infections.
Absolutely. I think you've ended on the more tough note. But we've made excellent progress, I can say. We could have done better, but we can live with the progress we've made. So currently in Kenya, we estimate that we have about 1.4 million people living with HIV. We estimate that about between 900,000 and 1.1 million of those are already on treatment, on effective, really powerful antiretroviral therapy. So we have a gap of anything between 130,000, 200,000 that we still need to get on treatment. So as far as that's concerned, we've really come a long way. The deaths are down 63% from 2000, from a height of about 200,000 deaths every year. We are down to about 35,000. I mean, that's progress to celebrate. New infections are also down about 53%, from also a height of about 200,000 in 2000. In the early parts of 2000, we down to about 35,000. So down 53%. What you mention is really what we. So in terms of new infections and deaths, we we're moving in the right direction. Okay. I would say we are not moving in the right direction, and what you mentioned is really the profile of the new infections is worryingly among young persons. So persons between 15 years and 24 years contributed up to 42% of new infections last year, the latest data we have. Yeah. And obviously that is a trend that we all must do something about. Yes.
So because they're new infections, obviously these are not those who are born with it. They are not cases of mother to child transmission. They are new infections, and we're looking between 18 and 24. So what is the nature then of the cause of these infections? Are we looking at sexual activity? Are we looking at drugs use with syringes? What from the research that has happened would be the cause of this infection?
So in terms of the what you may call the modes of transmission, so as you say, yes, 15 to 25, we are largely talking about those that are not from mother to child, which we can talk about a little later, where we've also made significant progress, but there's still quite a lot to be done. But these are largely, as you know, in this country, the largest proportion is heterosexual. So it's, as you say, it's sexual activity among these young persons, or in these young persons. We have a small proportion that is from injection drug use, which is obviously of a concern, and there's also quite good progress that is being made in that space. So I would say the largest proportion is really sexual, and then a small proportion that is injection drug use.
You know, the subject and the topic of HIV, important as it is, concerning as it is, somehow took a back seat when COVID came into town. To the point where I think for many people it was assumed that any issues arising from HIV had been sorted out and concluded. And then every once in a while, something about ARVs and issues around it pop up. Something around the availability of ARVs pop up. And so one is reminded. What is it that World AIDS Day hopes to achieve, kick off when you have a day such as this one, and more so when you have a theme such as the one we have for this year, equalize? What is this thing that is being sought after? What is it that we are trying to equalize? What are we trying to ensure that we achieve, not just on the day we commemorate the day, but going forward, so that it has the impact that we desire?
So thank you, CT. I think you mentioned a couple of very important things. Number one, the COVID epidemic or pandemic. One of the things that the COVID pandemic taught us is something around resilience. Can we have public health systems that can sustain gains in health gains, irrespective of shocks? Because what COVID-19 was a shock to the public health system, to the medical system, and what we know is that we didn't do a great job in terms of resilience. We let the ball drop, and therefore, a day like this, one of the things we need to reflect on is really how do we create resilient public and medical health systems. And really, when you talk about public health system, it goes beyond clinical care, beyond hospitals. It goes to society, it goes to communities, and so on. So I think that's one of the most important things that you raised there. So we know that the number of people that needed to be tested during the COVID pandemic went down. We know that there are people who missed their medication because of the COVID pandemic and the closures and the fear of going to facilities and all that. We know that, for example, there's now evidence that the number of TB cases that we needed to identify, we didn't quite identify those, which means people died unnecessarily from what you may call preventable infectious diseases like TB and complications of HIV infection. So I think that's the first thing. That yes, during that period, we did drop the ball because our public health system was not fully resilient. For me, who was almost in both world of COVID and HIV, of course, there are things we did to try and make it easier for people to continue accessing the care that they needed. So that's number one. Number two, a day like this, I think, which is to your second point, what this day help us to do is really to reflect. And to reflect on things like what you've mentioned, COVID. Can we build resilient public health systems? I think that's the first thing. And that's what everybody should be really looking at. You cannot look forward without looking back. So we have to look to the last 2-3 years and say, can we build resilient public health systems that can overcome shocks? And these shocks can be they say it's not if, it is when we have another pandemic. So can we build that kind of resilience? These shocks can be political. You would recall that during the unfortunate political violence that we have had in the past, really we also lost gains in terms of HIV prevention, care and treatment. And therefore they can, of course, we look to a future where we will not go back to a situation of political violence. So they can be economic. So, for example, during the COVID pandemic, one of the things that what happened is that people lost livelihoods. And those losing livelihoods put them in vulnerable positions, situations that increased their risks of disease, whether you are talking about HIV or other communicable diseases. So I think that's one of the things that really we need to be doing on a day like this. And then finally, in terms of equalize is really saying, okay, we have made this progress, but we have these pockets of vulnerability, and those are the pockets we need to eliminate. We have those that we have sadly forgotten. Those need to be lifted up. And the first place really to begin in terms of equalize is those gender norms and gender practices that put people in vulnerable positions. So we're talking about gender-based violence, for example. Can we really once and for all say we are putting the whole idea of gender-based violence behind us, and say that it's really not it's not something we should tolerate. So I think that's the first thing, that gender-based violence and certain gender norms put our compatriots, our sisters, our brothers in positions that increase their vulnerability and their risks. So that's the first thing. And also equalize in terms of young people. We've seen how the infections, 42% of all new infections among young people. So what are the interventions that we need to have that really support young people to protect themselves?
What are some of those, Dr. Because here we are just looking at reports that were done over time. If we look at the period between Friday and Monday, and now this is getting into the nitty-gritty of it. If we look at the period between Friday and Monday, the number of young people that are visiting chemists and pharmacies on a Saturday, on a Sunday, and a Monday morning is to get pregnancy preventive medication. And so obviously there is unprotected sex that is occurring, and the worry is not about STIs, for which HIV is one of them. The worry is about pregnancy, and it has been forgotten, or maybe it's not even being acknowledged, that there needs to then be care-seeking behavior when it comes to sexual activity.
Absolutely.
It's a big deal that 84% of the medication that is being sought for pregnancy prevention is being bought by people in this same age bracket, for which we are saying the rise of infections is most highly within. Obviously, we can connect the dots here.
Correct.
And it is clear then that the approaches towards this need to be targeted in terms of knowledge, in terms of education, in terms of advocacy. It doesn't mean that we have to reinvent the wheel, but it just means, from where I look at it, that a lot more work has to be done in those areas to be able to get the message home. Because there are young people who believe that they can't get HIV. And here we are seeing that they have the highest brunt when it comes to infections today.
So thank you. I think that's an excellent observation, which is actually backed by data. And so it's and you've mentioned some of the interventions, but I think the most important thing, as I said, is not to drop the ball. It's messaging. It is not to let the horror of what HIV infection is escape people's minds in terms of where we've come from. So we may be in a space where people are beginning to think, okay, we all celebrate that it's now a chronic, manageable long-term condition. But we really have to work on prevention. And you've mentioned some of those things. We have to continue putting emphasis on education, on awareness, on... for me, it's a great thing that people are visiting healthcare establishments of whatever definition for some kind of care. Can we wrap that around in terms of making sure that there is what you call comprehensive sexual reproductive health, so that it's comprehensive. It's not just pregnancy, but it is the whole package, including the psychological aspects, other infections, sexually transmitted infections, and all those other things. So comprehensive sexual reproductive health, but also really looking at beyond the health aspect into what you may call structural aspects. So what are those structural aspects that put these young people in situations where they take certain risks? Right. So are we talking about extreme want, extreme poverty? Are we talking about issues of parenting? So really improving parenting skills. Are we talking about situations of substance abuse? So really going into the whole area of substance abuse, and I'm sure there is now a very lively conversation about the sale of alcohol in various places around town. Have we made the access to psychoactive agents, and the commonest of which is alcohol, too common, too accessible, in a manner in which it is used in ways in which it puts individuals at risk of these infections and other things. One of the things, for example, looking at the data during the COVID lockdowns, if you looked at people coming to our emergency rooms, trauma went down. Yeah, completely. Like, we're no longer seeing trauma. Why did it go down? Because people were not drinking irresponsibly, and driving drunk, and getting into brawls in drinking places and all that. And as soon as the lockdowns were lifted, the trauma cases in our emergency department started increasing. So it's really the same. There is sort of some kind of correlation. Yeah. Between what you see as the totality of the negative effect of psychoactive, the irresponsible use, or what you may call unsafe use of psychoactive agents and the way people put themselves at risk, whether you are talking about HIV, other sexually transmitted infection, and trauma. And therefore, so I would say it's a whole package of looking at structural issues, looking at behavioral issues, looking at interpersonal issues, children versus parenting, and the school, how we engage schools as avenues, and are really availing what you may call comprehensive sexual reproductive health for these young persons.
Okay. It's now 29 minutes to 9 o'clock. Let's take a break. We're continuing on World AIDS Day today, talking about some of the interventions that are being made. And the funding issue is a big one, Daktari. Funding by, international organizations has been a big deal in the fight against HIV. We're going to come back and discuss that. It's Kenya's biggest conversation at 29 minutes to 9 o'clock.
This is the Situation Room. The only way to start your day.
AIDS Day, and we're talking this morning with Dr. Jared Mecha about some of the gains that we've made as the world and also as the country when it comes to HIV and the research, HIV and the treatment, the learning, the teaching.
Then there's the issue of the way forward. But the way forward can only be gleaned and be understood when you look at what is actually being done. Now, Daktari, the work that you do, what exactly is it? And how exactly does the funding that you get or hope to get or propose to get or might get play a role in ensuring that the goals you set out to achieve are actually achieved? Start off with, what do you do? What research are you involved in? What work are you involved in?
Yeah, so for the last 15 years, I've been part of leading, really designing and implementing programs that address making resources available for comprehensive HIV prevention, care, and treatment. And this is funding that comes from donors. For my case, through the University of Nairobi, to implement projects. And what we have done is implemented projects in parts of Nairobi County, parts of central Kenya, about 5 counties of central Kenya, or the Mount Kenya region, and also parts of Rift Valley, really covering a period of what I've mentioned, about 15 years, supporting close to 150,000 compatriots living with HIV, and also another huge number of persons at risk, making available resources for HIV prevention. So whether you are talking about people knowing their status, so making it possible for people to be tested so that they know their status, making it possible for those who are at high risk for HIV infection to access prevention interventions, including, condoms, counseling, what we call pre-exposure prophylaxis, post-exposure prophylaxis, prevention of mother-to-child transmission, and things like that. And also just building systems that support this work, whether it is it is at the community level or at facility level. So all the way from providing rooms, decent rooms for consultation, where patients can be seen in confidence, can provide their health information in confidence, all the way to using these resources to supplement human resources for health, employing doctors, clinical officers, nurses, counselors, records people, and across the board, really making available those resources for that work to be done. So that's the work we've been doing.
When you say making resources available, what are these resources that you make available?
So you are actually talking about money at the end of the day. So in this country, which is really another area of reflection on this World AIDS Day for our country, is that between 75 and 80% of the funds, of the resources that support HIV prevention, care, and treatment are external. They come from donors. Largely the US, what you may call bilateral, from bilateral resources, the largest contribution being from the United States government, but also multilateral donors, and the largest contributor being from Global Fund.
Yeah.
So that's obviously a great area of concern. In your house, if all the resources that you used to manage your essentials, including food and rent and other things, were from borrowed resources or from donations, you'll be very concerned. If 80% of your household was run, if that is even possible, by donations, it will be of a great concern.
Sure.
So I think that's one of the areas in terms of sustainability of the gains and ensuring that things don't fall through the cracks. That's one of the area where those that are in positions of responsibility to address financing, healthcare financing, need to seriously think about.
And that has been an issue for the longest time when we're talking about healthcare financing, whether we're talking about national budgets that ought to go towards health, whether we're talking about research budgets from the Abuja declarations to over and over and over again who has said what. But that the very healthcare of a nation can then not be dependent on what foreign donors will give, because at some point, even those taps will start to run dry, as we have seen. CT mentions PEPFAR. We're looking at huge dependence on research for intervention in the fight against HIV that has come from them. And we've seen a reduction of that over years, with warning from them that this would actually come to pass. It would reduce. Now, you talk about the vanguards of responsibility in the country being government largely. What needs to happen for this work to continue, for the fight to remain a fight, for the gains not to be clawed back on? What needs to happen?
So obviously the conversation, as you said, is been going on for very long, and what needs to happen is really well known. It's one of those, I think you call it a broken record. Everybody knows about it. What we do, from where I stand, and I think I stand in sort of very close to the middle of where the trouble is. What we do not see is commitment. Commitment, as you said, that it's not safe, that a significant proportion of our healthcare intervention is funded through donor resources. It's not safe. It's not safe for anybody, because the day these resources are not available, I can tell you there will be a disaster if people have not put action to the words. So the first thing is that what needs to be done is very well known, and what, from where I stand, is lacking is commitment. Let's start with, for example, a large proportion of these funds go into human resources for health, employing the frontline healthcare workers that support these services. Can we start by the national government and the county governments beginning to take up the payroll tab for these programs? I think that's one great place to start. There is some progress that has been made in the area of commodities. So the ARVs, the condoms, the testing, kits, and all those kinds of things. But still, the proportion by donor is quite significant. So can we also move into really also once and for all setting our supply chain right?
Can the government afford it?
We really cannot say we cannot afford it when it is about the health of the population, because that is the primary responsibility. It is there in their constitution. It's a constitutionally guaranteed right for Kenyans. And I think, as you say, the vanguards really have to say, these, of all things, very high up there with security and other things, we have to think about healthcare and the health of the population. We cannot say we cannot have. Because if you look at the economic losses that happened at the height of the HIV epidemic, where you will recall, we lost whole, professions. We had a problem, teachers. There are places where we had shortages of teachers because of this problem. As you said, there are whole communities that were devastated, and we lost massive amount of productivity. So there is an economic cost to ignoring a festering health issue. We all know the challenge we had with COVID. Literally just about nobody was making money because of the pandemic. So when we ignore preparedness for population health issues, we pay back by the shilling, and the economic losses can be massive. So it's really everybody's responsibility now to put action to what is very, very well known that needs to be done about financing for the HIV epidemic and actually all other what you may call in communicable diseases of epidemic potential.
Dr. It's something I have to ask. I mean, you've been a doctor for a good while, and any doctor in this country has worked for the government at some point.
Correct.
And you've probably had a leadership position within government at some point. Would you say that have we ever had an honest conversation about the costing of our healthcare? Because figures are always thrown up. We need this. And while we're at it, somebody will throw in the Abuja Declaration and the 15%. And yet, from what one observes, the preventative aspect of healthcare is completely ignored, or it's given very little attention. And yet, from a layman's perspective like myself, there's a thinking that is what would help control, if not bring down completely, this high cost of healthcare that we keep talking about. Because if you prevent the disease, there'll be no disease to treat. There'll be no problem with the disease. Where do you think we are at the level of the honesty of conversation? Because we are at the level of the honesty is that we are dependent on donor funding. Okay? And that argument seems to also indicate that we don't have sufficient resources. And I'm saying we might have sufficient resources. It's just that we don't have that conversation. Hence, do we cost our healthcare appropriately? Do we actually look at it and say, this is the best approach to do? This is how we ought to go about it, and this is what would achieve the results we want with our own resources.
So the first thing I would say is the conversation has been held. As I said, it's a broken record. We have had the conversation about healthcare financing in this country for a very, very long time. And as you said, yes, I worked for government. I have taken leadership positions in that. And I can tell you, we have experts that have looked at this. And they know exactly what it will be demeaning to some of the people who have spent their life in this area to say that conversation has been held. That conversation has been had. Let's start there. What I think the challenge is two things. One is prioritization. Is really prioritization. We haven't gotten to a place where resources are allocated to areas of priority. And that, I think, that is where I can say the honesty aspects come in, where we all know where the problem is, but we have problems of prioritization and putting resources in areas of priority. The second thing is really courage. Is taking difficult decisions.
Right.
Because when it comes to issues of money, which I'm not a great expert of, I know that you need to make very serious decisions which require courage. And this is a space, healthcare financing is one space where there are lots of what you may call interests. I don't want to use more difficult words than that. Lots of interests. And when you have a situation that's got lots of interests, what you need is courage. To say, with regard to as far as healthcare financing is concerned, I think this is the direction we should take, and we have excellent examples, both from studies, from research, but also from what you may call comparative health systems. We know places in this world where financing for what you may call the majority of the population happens reasonably well, and people enjoy really reasonable health outcomes with what you may call efficient allocation of resources. So if we just look to those examples, it should be possible for us to make those decisions. And then finally, it's a whole issue of really looking at healthcare comprehensively. As you said, the big buildings tend to be attractive, and everybody wants to build these, build the other, and so on. And at the expense of what you said, primary preventative healthcare and promotive. So, for example, we are moving into a situation where we're going to be having a huge problem of non-communicable diseases. We know that most of the non-communicable diseases are preventable at primary level. So you're talking about salt, you're talking about sugar, you're talking about screening for blood pressure, you're talking about screening for cancers that can be screened for. And those are things that can be done at primary level. If you ignore blood pressure, you lose your kidney, you go into dialysis, an extremely expensive medical intervention, because a proper identification of blood pressure at primary level, proper management at primary level was ignored.
Right.
So that's really the challenge, that we need to look at healthcare and the way in which we allocate resources to healthcare in a comprehensive manner, and we have excellent evidence of what is what gives you the best results for the shilling.
Dr. MTTC, mother-to-child transmission. We're looking at the HIV reports, which will come out today at the launch of World AIDS Day. One of the things that they have said is that in the next 8 years, by 2030, we should see an end of infections of newborns by their mothers. What would it take to make this happen? And from the work that you've done, do you see that this could actually be done?
So absolutely. So really, at this time and age, we shouldn't be having any child born HIV positive because their mom has HIV infection. It shouldn't be happening. So if I can give you examples of the programs that I've worked in. So when we started working in some of these programs, we had mother-to-child transmission rates of anything between 10 and 15%. And within 5 years, we reduced that to less than 2%. It can be done. If you look at most programs right now, what we call within program. So within a program, you have what you call a cohort of mothers, and the totality of those mothers that are attending antenatal clinic, you test, which is the first thing that every mother really should know, their HIV status. And then those who are HIV positive, you put on treatment and so on. So within programs right now, most are reporting mother-to-child transmission rates below 2%, or at least below 5%. But when you look at the national profile, for example, we are talking about 8 to 11, percent. Those are the kind of figures that are being given. So what's the challenge? If you look at outstanding aspects of where where we're having children born of with HIV infection. Number one is mothers who have been on treatment, who for some reason have discontinued treatment. So we really must have all women, as we say, of reproductive age who are living with HIV receiving effective antiretroviral therapy and staying on effective antiretroviral therapy for their own sake, for their own health, but also for the sake of the babies. The second contribution is really those who are not known to have HIV infection. They are expecting, and then they're identified, and usually they are identified late. So what we are saying is that really we need to have interventions where every woman of reproductive age who has intention of starting a family, really knowing their HIV status. And then finally, the final group are those who are on treatment, so mothers who are on treatment, but their viral load is not suppressed. So the virus is not suppressed in the system.
Right. We
have treatment now that can suppress the virus to undetectable levels, and now we are talking undetectable and transmissible. So if a mother has HIV infection and their viral load is undetectable, they will not give it to their unborn child. Equally in terms of sexual contact with an undetectable virus, someone will not pass it through sexual contact. So those are some of the things that we need to do, really providing what you may call a comprehensive prevention, care, treatment interventions for all women of reproductive age, beginning with community. So we have community interventions and we have health systems interventions, which really must be very strong to sustain the gains.
How readily available is this information? I mean, sounds really wonderful, but how many people know this? How many people understand that this is available, where they can get it?
So we do our best within the programs, within the facilities that are supported within whether you're talking about government facilities and private facilities, to ensure that this information is available. But also I think that is the other issue around a day like this. A day like this is to reinforce the message and to say we cannot let the message drop.
Right.
So for example, we know there is something called PrEP. So N1, pre-exposure prophylaxis. And this pre-exposure prophylaxis...
Just explain prophylaxis, that though it is understood.
In a short while,
in
about a short minute,
Yeah, so it's really prevention. It's prevention. If anyone knows that they are at increased risk of HIV infection, they can take these medicines. They are now available in tablet form or even in injection form.
Yes.
And this injection is long term. Somebody can take an injection and they will be protected for a period of. So this information is available, and what we are asking people really and telling everybody, let this information go out. Yes.
Dr. Harry, thank you for joining us this morning on this World AIDS Day. It would be great to see the gains that we continue to make in the fight against HIV. Asante Sana for being in the Situation Room this morning.